Okay, great. Hello, everybody. I'm here at Dante Pazanese again. Thank you very much for MedStream 360, especially to our friend Samir Mehta, who gave us this great opportunity to share what we do here in our cath lab. So we have here an outstanding team of physicians. Dimitri Siqueira, as you know, is here in my left. He's going to be the first operator for this case. Ricardo Costa, you also know, who is going to be helping Dimitri in doing all this, the procedure. And also we have the 50-year fellow, Michele Bircher. We have a great team of echo. If you can show the camera over there, Vanessa Andreoli is going to show you the images from echo and in this case. And we have a spectacular team of nurse in my right here. And the chief is Fernanda, and all the technicians and all nurses will be working with us. So, Dimitri, you have the slides? Can we
Yes,
go
yes,
direct to the
Fausto.
case? Okay.
So, thank you, Fausto. Let me present our patient for today. This is a 83-year-old lady, non-frail, independent. She has a high BSA and a past medical history. She has hypertension, dyslipidemia, and a permanent pacemaker. This patient presented to our hospital with symptoms of heart failure due to aortic stenosis, and on perioperative risk assessment, the Euroscore 2 is 1.3 and the STS score 3.4. So she was deemed a low-risk patient for surgery. These lab tests, you can appreciate she has a normal renal function with a GFR of 86. The BNP is mildly elevated. She has a permanent pacemaker, like we said before. He's on pacemaker rhythm on the EKG. And the echo findings you can appreciate here. She has a preserved LV function with ejection fraction of 62. She has a mild mitral regurgitation and a moderate mitral stenosis with a mitral valve area or 1.7, right? And the aortic valve is calcified with a mean gradient of 43 millimeters of mercury and an estimated aortic valve area of zero 0.6 square centimeters. This is the CT workup. She has a small annulus with a perimeter of 67.5 millimeters. The Valsalva sinus diameters are 28, 29, and 29. And she has a tricuspid calcified aortic valve with a calcium score of 1060, around 60, 600. And here you can appreciate the STJ, the measurements. The ascending aorta is not dilated. And of note, this patient has a low origin of the left main, 8.5 millimeters. The RCA height is good, above 12 millimeters. We proceed with a detailed analysis of the left main distance and also the left coronary cusp. And you can appreciate here, as I said, he has a low coronary takeoff on the left. The VTC is around 4.5, and the calcium volume at the left leaflet is below 600 millimeters square. So here she has, let's say, moderate risk of coronary obstruction. These are the angulations, the estimated projections that we're going to use for valve deployment. And on CT reconstruction of the iliacs and femorals, he has good diameters, some tortuosity on the right, and a high femoral bifurcation on the left. And we also proceed with analysis of the aortic arch and branches, just to evaluate the anatomical suitability for the use of Sentinel device. So, Fausto, in summary, 83 lady with severe symptomatic aortic stenosis, non-frail, low surgical risk based on the scores, and some anatomical challenges for TAVR, low coronary takeoff.
So you mentioned she has mitral stenosis. Do you think the cause of this is only calcification in the senile calcification, old calcification, or some rheumatic fever in the past?
It seems that it's a degenerative mitral stenosis. She has some calcium on the mitral annulus. But we investigated with echo and by experienced operators, and she has a moderate mitral stenosis.
Okay.
So we think that the most problem that we're gonna proceed here is the treatment of aortic stenosis.
She's a small lady. She's only 145 centimeters, but at the same time she's obese because she has 85 kilograms.
Yeah.
So is there any specific comments about this?
Yeah, this is an important issue because she has also a small annulus. So she has some risk of PPM, of patient prosthesis mismatch. And our plan is to use a self-expandable valve just to get good hemodynamics post-procedure.
So in this situation, she has a small annulus, like we mentioned. She's only 145 centimeters, and she also has a low coronary takeoff of mainly the left. It's 8.5. Is there any specific consideration to choose a self-expandable valve because of this or not?
Yeah, particularly in this case, we choose an accurate NEW2 valve. I'm going to show some slides that can corroborate my opinion here. This valve has a very low incidence. In fact, no case
has
reported so far in the literature with coronary occlusion after the accurate NEW2.
Do you want to show the accurate right now, or do you want to show what you have done so far?
Maybe we can show our strategy here for today and proceed with Sentinel implantation.
Yes, great.
So we're going to perform this case in conscious sedation with a minimalist approach. We're going to use LV wire pacing for predilation.
So what is your experience in here with the minimalist approach? Do you discharge the patient the next day? They usually don't go to the CCU or something like this?
Yeah, in our experience, majority of patients, let's say 80% of cases, they are discharged next day.
Okay, great.
So maybe Ricardo can show also what we did so far here.
Ricardo, please.
Yeah, so here we have already with vascular access in the right femoral artery. That's when we have the delivery system, the iSleeve, which is already in place. It's a 14 French dedicated device to advance the valve. So it's already in place here, and we have a guide wire in position so we can advance with AL1 to cross the valve, what we want to do live.
Okay.
Here on the left femoral artery, we have a 5 French sheath, and we have a pigtail, which is going to be placed.
So both punctures were guided by ultrasound?
Both punctures guided by ultrasound, which is our routine as well. And also we have here in the right radial we have a
Yes.
sheath positioned here
Uh-huh.
that we want to also demonstrate and advance, which is perhaps one of the great innovations nowadays in terms of improving the safety of the procedure, which is to advance a cerebral protection device.
How do you see the recent results of the trial that tested the Sentinel to
Yeah.
protect the embolic event after TAVI?
Yeah, in the
Oh, yeah.
PROTECT trial, we
Pode
could
pôr.
see that
Pode
the
pôr,
primary
pode.
endpoint, which was based on not only on disabling stroke, but overall.
Excuse me, Ricardo. Can you please show Michelle hands, please, here, right here? My hand. Okay, great. Right here.
Yeah, and the
Okay,
angel too. Yeah.
okay. And also, may you have the angel in the screen, please? Angel in the large screen. Great. We are just advancing the sentinel through the radial arteries. I'm sorry, Ricardo.
No, no
You
problem.
can go ahead, please talk.
So I was saying that in this trial, no significant benefit was
Okay.
observed.
May you have the angel in the screen, please? Is
And
that possible? Hello? Okay. The angel. Is our angel connected to you or not? Because I heard. Yeah. Okay, all right. Thank you. If you have problem, maybe you can show with the camera that it's above us, our monitor here, if you have problem.
So Fausto, we're gonna
Okay,
deploy.
great. Okay.
perfect. Yeah.
So we're gonna deploy the first
Thank you.
filter, the proximal one.
Okay.
So there's a slider here on the handle,
Uh-huh.
the one slider,
Okay.
and I'm gonna unsheath the proximal filter.
The proximal filter is going to open there.
Okay.
Which level should you open that, Dimitri?
We did an angel before, and we have also the CT. The first filter should be below that calcium that we see on fluoroscopy,
Okay.
and we should not advance the filter to the aorta.
Okay.
You like
So-
it?
Just being well deployed. So
Yeah.
Fausto, just to
So we also have the people from Boston Scientific. You are here to help us.
Yeah.
So you are Diogo. Diogo is here with us.
So just to complete, I think there's some good news in this trial that the rates of disabling stroke were very, very small. But when we take only disabling stroke alone, we could see a significant benefit.
Okay.
So if you think for one patient that happens becomes 100%.
Okay.
So I think if you can use it, of course, you enhancing the safety of the procedure.
Great. So what are you doing, Dimitri, now?
So I'm gonna try to orientate the tip of the sentinel
Oh, that's
to the
great.
left carotid.
That's a great demonstration. Great. So you're just turn around and going up to the carotid. Let's see. It's
No.
going up.
No.
Yeah, it's very nice to see the handling here. So you're doing clockwise, right,
Okay.
Dimitri?
Yeah.
Yeah, but then maybe it's unclockwise. You need to go there. No? Yes, unclockwise now. Clockwise. Yes, great. You're getting a good position now.
Okay.
You're advancing.
This is the. I think it's the subclavian, right?
Uh,
I'm not sure. I think
Yeah.
you're.
let's see. Go. No, yes. You're going to the arch. So you're going to get the right carotid artery. Is that your
The left
intent?
carotid.
Left carotid first. Okay. Yeah. Dimitri is advancing a little bit now. We're at the arch now. And the tip of the wire, as you can see there, is rotating and trying to get the left carotid artery. Sometimes it's not completely easy to do this through the radio.
Okay.
Now I think you got it. Yeah? Yes. So you're in the left. Let's see.
I think so.
Yeah.
So and this is a 0.014 inch
Yeah.
regular wire.
Yeah, it's a
Dimitri?
regular guide
For like
wire.
a coronary.
Yeah.
Okay.
Okay, good. I think you are not there yet. No. I,
It's there.
if I can give you,
What do
you
you
an
think?
opinion, the left corner, I think it's a little bit to the right, the left carotid. Yeah.
Let's see the angel here just
Yeah. Yeah.
to identify
Yeah.
the.
Yeah,
Yeah.
it's just in the middle. Yeah,
Yeah.
yeah. You're right, Fausto. It's just the calcium there.
Uh-huh.
Yeah, it's
Yeah.
closer to the.
Yeah. We need to be so patient here with in advancing the system. Because it's a guide wire, it's only 14 wire. Usually, when we get this to do a diagnosed cath, we use a 35 wire and guide wire. So now,
Yeah, and Fausto, this is we have seen in some places this has become already routine practice, and in about 80 to 90% of the cases you can do it. You know,
okay,
in 10 to 20% you can face some anatomical challenges.
okay, yeah. This is there is a challenge. No. Do you want to take a look in the picture and put the picture here? Can you?
Sure. Can you stop a little bit,
Dimitri?
Dimitri?
Yeah. It's
Não compressa, por favor.
usually it's helpful when you have exactly the picture. Tira um pouquinho o pé, Dimitri, só para ele colocar aqui. Okay. Now we. Okay. A little bit more dye there. Okay. See, there's a tortuosity in the subclavian, and also in the brachiocephalic trunk.
Yeah. Looks like it's tortuous, right?
Tortuous,
the takeoff
yeah.
is some tortuous. We can see this by the angel.
Okay. Are you in the same view that you acquired here? It's 30 by 0. Okay. Let's see if it's possible. Okay. Now you got.
I think it's there, right?
Yeah, I think it's there.
Yeah.
You see there? Yeah.
Okay.
So you're advancing here the distal filter, right?
Yeah.
And how far should you go in the carotid, Dimitri? Okay.
No, it's not there.
No.
Retract here.
I think you need to do a curve of almost 180 degrees.
Looks like it's just behind that calcium there.
So there is the tortuosity. Oh, no, I need to go up. It's right here.
Yeah, they're very close. It's like overlap, you know, the right,
No, I think
the left subclavian and the carotid. Oh, now you're there. I think now you're there.
Yeah. Yes.
Now you're there.
You got.
Yeah.
Great.
So
now you're advancing the system.
Yeah.
So you have the wire, the guide wire in the left carotid artery.
So
now, yes, great.
Advancing off. Okay.
Good job.
Very elegant demonstration.
Yeah. Yes.
Yeah.
When you have some difficult, you need to be calm and just going clockwise, unclockwise, very patient.
Yeah. Have you reference.
You cannot get stressed and doing this in life.
Dá uma compressa, por favor.
It's great. We have a TV man here in Brazil. His name is Fausto, the same name that I have. He also usually says,
when you know, you do it.
When you
do it live.
Yeah, you do it live. When you know.
So let's cross the valve now.
Okay, so AL1.
Yeah.
So in this device, I mean, there are several devices being tested nowadays. This is the only approved in Brazil, and this is the most used, of course, in the world right now.
Good.
But the advantage of this device is that first is a low profile. You can just have like
So
a radio.
it's there now.
It's there in
Then
position, and you can just continue your procedure.
okay.
And the another advantage is that you can capture and retrieve any material.
How about the right
know.
carotid? You do not protect.
We are protecting here at the level of the trunk. Okay, so
I mean the right, the
you
right.
So we
Yeah.
can't protect the left vertebral circulation
Okay.
with this device.
Okay. Good.
Straight
to-
wire, please.
so now we're advancing here straight wire to cross the valve, and qual a projeção?
Pode ser essa mesmo.
We're gonna work in this projection at this
Okay.
time. Okay.
Now we are bringing the Amplatz catheter with the guide wire. It's 35 straight.
Straight, short. So
Sure.
we want to first cross,
Okay.
and then we're gonna advance the AL and Platts AL1, and then we like to exchange for a pigtail to measure the gradient.
Okay.
Some people like to just go straight and already implant the valve, but we like to do this routine
Okay.
to also document.
Okay.
And
Now you
see-
need to cross the valve very carefully because you have a straight wire to avoid any complication. Everything that we do here, I think we need to be very careful because we are working with a lady who is 85 years old. Everything can be different when you are working in a young man,
Yeah.
and you can hurt
Yeah.
her heart.
Yeah,
If
absolutely.
if you don't do it very casual,
Yeah.
like we saw Dimitri work with the sentinel position.
Yeah. In this manipulation, even a diagnostic cat, if you're not very careful, you can cause embolization
Yes,
and cause a stroke. So
definitely.
this is something we teach our fellows to be very, very
So,
careful.
so as you saw, Dimitri changed the position of the view. In his view, he was working in LAO. Now he is almost in the PA and the posterior anterior, or AP. Now
And
to
you
get
see
across the valve.
And you see some degree of aortic insufficiency
Yeah.
and keeps like bringing the leaflets up.
Uh-huh.
So it's very difficult to stabilize. Sometimes you get to be closer to stabilize. But this is
So it's very nice to do a procedure since the beginning. So you did the punctions under ultrasound guided, and after this we are doing everything in life, as you can appreciate. If you have fellows or even physicians who are starting doing the procedure, it's important to see all the rules that we follow here.
Yeah, and this is very teaching. And such we have, we imagine this audience, a lot of fellows and people in training as well. We have now in our institution a program, right, that we can do in the routine these cases, and it's really teaching to see different degrees of complexity. And I think a patient like this really represents what we're seeing now, more than 80 years old, frail, and
it's very important also when we are doing live cases, and you have Ricardo and myself make the comments, and Dimitri is just concentrating and working over there.
So Ricardo, we have some slides about the accurate new. Maybe you can show the slides when I try to cross here.
Okay, may you have the slides and on the screen, and while Dimitri is trying to cross the aortic valve? Yes. So this is the case summary. You can tell.
So the procedure strategy, as we have discussed, this is a minimalistic approach, as we mentioned. It's a conscious sedation, a transthoracic echo. We plan to use a LV wire pacing, so there's no pacemaker lead position there, and the patient already has a permanent pacemaker. That's another thing that we have learned over time. Why not use the permanent pacemaker, and just to change here the controls, because it might take too long to put a new adjustment and then to bring back. So that's why we plan to do like this. Large bore access, as we mentioned, is one per close only. That's another thing that we work in this minimalistic approach. The second axis, we just demonstrated how we deploy the Sentinel. And the plan here is to use a self-expander accurate new with commissure alignment, which is another technique advancement to prevent even more coronary compromise, coronary occlusion.
That's perfect.
Here we have a illustration of this valve. Important to say also that this has been this valve has been firstly in the world deployed in this institution in the first in-man series. We have more than 150 cases already deployed here, and it have some interesting features. It's very stable, improved hemodynamic, it's very easy to use, very predictable, and also some enhancements here with this new version, this radial plaque positional markers for the placement accuracy, and also a most accurate commissure alignment, as well as the outer skirt to prevent paravalvular leak.
Ricardo, I'll ask you just to mention this later when you have the valve and we can talk. Dimitri, I think has. Can we go back to the screen, please? The fluor, great. So what you did to get across?
So we just cross it with carefully, just to minimize the risk of embolization. And now we can see the hemodynamics.
May you have the hemodynamics in the screen, please? Oh,
So
okay.
we-
So you tell,
Yeah,
please.
we always measure the
Maybe you
the-
can use this camera here to there. Okay, thank you.
Coloca
So-
mais para trás a tela.
So after crossing, Fausto, we always exchange the Amplatz catheter to a pigtail just to measure hemodynamics, and you can see, but
Pega já.
here we had a gradient about 70 millimeters per mercury, and we think that the pigtail also helps to place the extra stiff wire carefully in the left.
Great. Now we have the
ventricular
hemodynamics.
cavity.
It's great. We have the hemodynamics in the screen, Dimitri. It's great. So you can do some, how can I say, improvisation.
Improvise. Yes.
Improvise. That's great. Great technician. So we can see the hemodynamics. Now can we go back to the Dimitri hands? He's going to exchange. This is an important part of the procedure. I have seen some problems when you place the stiff wire and causing some perforation in the left ventricle. And you don't see, after you deploy the valve, you see some pericardial effusion. So at this point, Ricardo is helping Dimitri to take the wire out, I mean the pigtail out, and he's gonna keeping the stiff wire over there with that special curve. What kind of
This
wire?
is the Safari Exo
Safari.
Small. She has a small left ventricular cavity.
Do you like this position? Can you make some
yes,
comments?
I think so. We always position in RAO projection just to make sure that the tip of the catheter is in the apex of the left ventricle.
So now we are going to proceed with the predilation.
Yeah.
So when you implant accurate, you always need to predilation or you can do direct implantation?
So it's highly recommended that you predilate. We predilate in the majority of cases. We have done some cases without predilation. For example, patients with aortic stenosis due to radiation with not a lot of calcium, and some patients with aortic regurgitation. But I won't say mandatory, but highly recommended that you predilate it.
What balloon size you are using now to predilate?
So Fausto, we're gonna use a 20 balloon.
So you can measure the coronary osteum with the balloon and to see how it looks, or
I don't think it's necessary on this
because
case.
we're not here going to do a balloon expandable.
Yeah.
We are going to use a self-expander. Is that the reason?
Sorry.
So we are going to use a self-expandable. If you
Yeah.
were using a balloon expandable,
Probably
it would make sense.
go without predilation.
Okay.
So let's perform check the rapid pacing
No,
here.
but I'm talking to use the balloon just to see how high is going to be the valve implant when you just test with the contrast.
Okay.
Yeah, when you have very low takeoff of the coronaries, this is a procedure that you use
What I'm talking about.
to see whether you expect to have an occlusion
Okay.
of the coronary.
Okay, good.
Here,
Vamos
maybe
testar o marca-passo, por favor?
the height is already okay.
Now we are going to test the pacemaker.
Pacemaker on. Colocar 100, por favor.
Yeah.
120.
It's 120.
Ok, pode desligar.
Okay.
Pode desligar.
Pacemaker
off. So I'm gonna position the balloon here.
We just cross the valve here.
Yeah.
Ok. Pacemaker on. Pode ligar 100.
100. Pacemaker on 100.
120.
120.
180, por favor.
180. And now we're going to inflate the balloon there.
Ok, desinsufla. And pacemaker off. Okay. Let's remove the balloon here.
That's enough?
Yeah, I think so.
Here.
Let's see the angel, just to see how the balloon expands. I think it was a good predilation.
Okay. So do you see anything different, Vanessa, in the echo?
Pode tirar.
No,
Everything is fine?
it's okay.
Okay. No,
Hemodynamics are good here.
no regurgitation, no aortic regurgitation, or
No,
just
that-
mild?
Mild,
Mild
mild
regurgitation.
aortic regurgitation.
Okay, thank you. Ricardo now is removing the balloon and keeping the wire, the stiff wire in the LV.
And now we are ready for valve deployment.
Yes, great. Now we are going to try to explain, because we started doing this using the accurate new more than 10 years ago. So the first in-man experience was here at Dante Pazanese.
Shall we show here?
Yes, can you show the camera and the Ricardo hands, please? Just to show the valve. Right here. Okay. Let's see.
Okay, so
great.
we have maybe a zoom here.
Yeah.
So in this valve, we have a upper crown that it's a supraannular position anchoring, and then you have the lower crown where you have the valve itself. As we mentioned, we're going to demonstrate it's a very user-friendly delivery, very stable, that improve the hemodynamics very rapidly, and we have insides of small, medium, and large. So in this case, we're going to go with small.
Right?
Great. So we have
pouquinho.
used this prosthesis in about 150 cases. Is that correct, Dimitri?
Yes.
Right now?
Yeah, our experience at Dante, as you said before, started 11 years ago with the Cymetis. We did the first transfemoral cases with this valve.
So you are so fortunate here in Brazil, because this valve is produced here in Brazil. That's very important to mention. Boston Scientific has a factory here in Belo Horizonte, in Minas Gerais, is the next state to São Paulo, and they are producing this valve for the world. Is that correct? Okay.
So we're gonna try to get a commercial alignment. So it's very important to maintain the flushing port of the system.
Can you
facing
show here?
down?
Can you show the hand, Ricardo,
at
hands now?
90 degrees.
Yeah. Can you bring the camera here? Okay. Just a little bit back from this, behind.
Hold the wire. Hold the wire.
I'll try to show you my hands, and you see. Follow my hands. My hands. Right here. Yeah. Okay. Great.
Mantém o guia, não. Empurra o guia. Empurra o guia. Empurra. Ok.
So Dimitri, do you want to say something about
Okay.
this?
Yeah. Yeah. It's important to keep the wire on the greater curvature of the aorta, just to get a precise positioning of the
And
valve.
just to show here, so this is the safety port and the flushing port. They need to be like looking down here 6 o'clock to get the commissural alignment.
So I'm gonna dock the loader here. You keep the wire on the greater curvature, Ricardo.
Yeah.
Please. Push, 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 push the wire, push the wire, push, push. Okay, that's fine. And we are advancing the delivery system. It's very flexible, very deliverable. And we're gonna cross the aortic arch. And then we're gonna try to do the commissural alignment. Film here. Puxa um pouquinho o guia. Okay. You can see that it doesn't interact with the sentinel, right?
Okay.
And then we're gonna use the cusp overlap projection. That is what?
So the
36
position
RAO.
already guarantees a good position, but now that's a final adjustment, right, for the commissural
Yeah.
alignment. That's what we're going to look for now, changing the
36.
view.
36 RAO.
Caudal 37.
So what Michelle is saying, it's
Quer que
just
puxe
in
meu
telling
aparelho?
just telling Dimitri the right position. That was the best position for the cuspid and also the alignment, the valve. It's 37 RAO and 36 caudal. Is that
So
correct?
here we can see the free stent edge, right? Very nicely. And then we're gonna move to the left just to see if we can get
So it's important to see multiple views.
it looks like that we need some rotation here just to see the stent edge. I'm rotating here. It seems better now, right? Don't you think?
Yes.
Okay. Here you can see the three posts, right? And free stent edge at the right hand of the screen.
So it looks like the ideal
Yeah.
position, right, Dimitri?
The pigtail is also on the non-coronary cusp. And then we're gonna proceed with valve implantation.
Shall we go back to the view, Dimitri?
No, we're gonna use the
Okay.
LAO projection. Is 18 by 28 cranial.
So 8.5 millimeter distal from the left main, do you think we should protect it or not? The left system.
You mean to protect?
The coronary
We are
artery.
very confident that we're gonna
Okay.
place this valve at the right spot and not occlude the coronaries.
Okay, good.
So you see the marker there in the middle of the valve should be just at the lower level of the pigtail, the curvature of the pigtail.
So let's do the first injection here. Injeta.
So the mark is exactly in the,
to start.
Yes.
Good to start?
Yeah.
So the marker, just to explain the audience, so the mark is exactly in
at the
position,
bottom of the pigtail, at the annulus.
Okay.
So we're gonna start the deployment here.
I'm starting here. I'm rotating here counterclockwise.
Okay.
You don't have to be fast here.
Uh-huh.
See, the patient has very stable hemodynamics, and we're expecting here is to open the
Okay. Open the first
open
now.
the upper crown.
Let's
Upper
do
crown.
another injection here,
And
Ricardo.
this is the position, Fausto. You can still
Okay.
have the final adjustment here.
Okay.
Okay.
Another
Injeta.
Okay. Injection.
Okay. Looks good. So this is the same position that we started.
Tô fazendo.
Continue.
Só um
So
pouquinho.
unclockwise again.
I'm doing some forward pressure here.
And I'm continue here.
Uh-huh.
Okay.
Let's release the stabilization arts.
Okay, you are keeping like you're implanting a coronary stent. You are just keeping with your left hand. The mid left hand is just holding and pushing a little bit.
So it's
You notice that the valve centralized in the annulus.
So-
It's more coaxial now.
Yeah,
I completed here the opening of the upper crown
upper cross.
and the anchoring.
So you can still
top as well.
make an adjustment of the position, or
Yes, you
Foi
can.
tudo, foi tudo.
Okay, let's do another angel here. Injeta.
so it's, I
Looks
think
like a
it's,
good position.
it's still in the same position you started. You
Yeah.
did a very nice job here. Yeah, the marker, if you can observe, is exactly the point we started in the pigtail position. So
Very stable.
very stable.
And the patient is
So
very stable too.
we try to correct the parallax here, Ricardo, just before the final deployment.
Okay.
Let's do another angel here. Patient has a normal renal function. Injeta. It's a good position,
Do
right?
you like this position,
Yeah.
Dimitri?
So Ricardo is gonna remove the safety
Here's
button.
a safety button here that you just
Okay.
press and you remove this. And now
We're gonna rotate quickly
it's
the knob
it's a
two.
faster rotation here.
Okay. All right.
Okay.
So go all up the end and the valve is released.
Okay.
So patient is very stable.
Great
And
demonstration.
we're gonna check the echo now.
So the blood pressure is fine. I can tell you because you are seeing the hemodynamics, and Vanessa is going to do the echo and to see some regurgitation, pericardial fusion, and also the LV function because of the coronary artery. I mean,
Some
the left system.
careful remove also, Dimitri, the nose cone, right?
Yeah.
And then we should have a visual direct visualization to reposition before retrieving.
Sometimes when you have a small anatomy, very calcified, and the valve is not so expanded, you have to be very careful in removing the nose cone from the left ventricle. And now, as Vanessa is checking the echo, we're gonna do the resheath of the system.
So start with the,
So start with knob 2, rotating clockwise.
so I'm
And
doing
we can
here,
see here the nose cone moving backwards to the stent holder.
okay.
Okay, and then knob 1, and the two radiopaque
So go up to the marker, right?
Okay.
Yeah, just up to the marker.
Like you are capturing
Yeah.
the nose cone.
Yeah,
That's
resheathing.
great. That's
Yeah.
great.
Yeah.
So
And
now,
now
we're
we can
position-
remove the system from the body.
Okay. A great demonstration how to take everything out. Great.
So Vanessa, how it seems on echo?
I think it's very good. It has no leak or little leak paravalvar, and the valve processes was
Mhm.
checking now.
Do you see
Okay.
any leak?
Just
Any
smile.
paravalvular-
Just smile. Just
Just smile.
smile.
So let's put a pigtail on the left ventricle and then remove the guide wire, because
Pig.
sometimes it helps to
So
evaluate.
you were mentioning about a small annulus and calcified valve, and to do when do you do a post-dilation in a case like this? When you choose, when the gradient look at the paravalvular leaking, or
with this valve, the gradients are
quite low.
quite low.
So
I would say
I'm asking,
all-
how do you make your
in every
decision?
patient, let's say in bicuspid, after a valve-in-valve procedure, maybe we get some gradients, but in general, the gradients are very low.
So the
And we
paper,
pause dilate only if a patient has a moderate paravalvular leak,
so
mild to moderate paravalvular leak.
the paper you published 4 years ago in the CCI and talking about 104 cases that you have done here, what is the incidence of post dilation? Do you remember that?
Let's say 30% of cases.
30% of cases.
And on that experience, we are using the previous version of the Accurate, the Accurate New 2.
Okay.
So without a skirt. So
Okay.
at that time, paravalvular leak rate was higher than we see today.
So do you think the skirt helps to avoid?
A lot.
Okay, great.
Let's say that the incidence of
So the new,
moderate to severe paravalvular leak is very low in our experience nowadays.
the new valve is much better than the old one, and mainly
Definitely.
because it's made in Brazil. Yeah. Okay. I'm just.
So let's see the hemodynamics here.
Okay. So if you want to bring again the camera to our monitor, it's going to be great, if it's possible. Just to bring the camera to the hemodynamics, please.
Dimitri tem leakzinho discreto.
Okay.
Fausto,
E o gradiente de 2411, tá?
Okay, now you're showing the echo. The echo looks good. What is the gradient, Vanessa?
So this is the little leak paravalvar.
Uh-huh.
And the gradient, I estimate a medium gradient of 11 millimeters of mercury.
Uh-huh.
And the no pericardial effusion.
Okay, great.
And the contractility is normal.
Okay, great.
Vamos zerar.
Great, Vanessa, thank you. Dimitri, so the
Vamos zerar a pressão, por favor.
I mean, you are talking, the mean gradient is 11, the mean gradient?
Medium.
Medium.
Yes.
Medium.
Pode zerar.
So Dimitri is checking.
Is there any intraventricular gradient?
No.
And Fausto, just to say, that's a recent presentation at the EuroPCR with this valve up to 5 years follow-up, 120 patients. Very similar profile of this patient, mean age about 85. And the rate of pacemaker, the new pacemaker was 13.3%. But importantly, most of these patients, they have previous EKG disorders.
Okay.
When we don't have, that's about 6-7%. That's what we see in practice.
Very important you mention this. So the overall pacemaker implantation was 13%.
13.3%, yeah.
So in our experience, it was much lower than this, Dimitri?
But a lot of patients with previous disorders.
Okay.
If you don't have previous disorders, 6.
So Dimitri, how was the pacemaker implantation and our first experience in man?
I think it was 7 or 8%.
We are going to show in the next case, because we're going to implant in the next case. It's going to be a very interesting case, a new, accurate new again in the next case, in the next lab. Dimitri is just checking the gradient. What was the gradient here by hemodynamics, Dimitri?
Around 6.
6. The maximum?
Peak gradient of 6, 5, 6. And let's do an angel here.
So when you measure the gradient and immediately after you deploy the valve, it's a little bit higher than you can measure like 30 minutes later.
If you wait some minutes,
have you
let's say
that?
10 to 15 minutes,
okay,
possibly
great.
that this gradient
This is very important. The hemodynamics change over time.
Okay.
In the next day, 30 days, 1 year.
Okay.
Because it's self-expanding the properties of the nitinol.
Okay, great.
Very important point. That's why sometimes you accept, some degree because you do know the hemodynamics will improve. This has been demonstrated.
Pronto? Inject.
So the pigtail is a little bit higher. Is this the right position to do the a little bit down? Huh?
But I can't see any leak, right?
Yeah. I don't see any leak. No. I don't see any insufficiency even.
Yeah, but I'm telling you, if you have a little bit lower.
Okay, we're gonna do that.
Okay.
And you're the boss.
To measure, yes.
And also for
the left main is open.
The patency of the
I look at that. I look at
left main is patent.
The first thing that I look at that was the left main.
Vamos fazer outra, por favor?
Yes. Again.
Injeta.
Oh, I like much better this. So,
Yeah.
so the left main is absolutely great. You have some struts pretty close to the left main, but you are
Yeah.
quite sure that even with 8.5 millimeter distance.
But I think, Fausto, that we got commissural alignment,
Uh-huh.
as you can see here.
Uh-huh.
We can even try to cannulate the coronaries right now, just to show
Yeah.
how easy it could be.
Uh-huh.
But in terms of regurgitation, I think fine, right? It's a good
Great.
Oh, it's fine.
position.
We're
Fine.
very
The
good.
Absolutely
coronaries
fine.
are
So and
patent,
also the
low
gradient is good.
gradient.
Yeah.
So the mean gradient that Vanessa looked at it was about 11.
Yeah.
It's still a little bit high, but I think, can you measure the gradient again, Vanessa, please? Could you please?
And maybe, yeah.
While Dimitri is working in
And
some.
also another important finding in this registry that was presented at EuroPCR, no cardiovascular death and no peri-procedural MI
In more
related
than
to the image
1,000
procedure.
patients?
No, 120
On
patients. This
120.
registry, yes.
Okay.
But showing the safety and no compromise of coronaries. So
So there
very,
is a registry with 1,000 patients too, or not? This is the largest
no,
registry.
I think this is not the
was a-
largest, but with the longest follow-up.
Yeah.
Longest follow-up.
Okay.
There was a preview registry with accurate new, the previous version, and the coronary occlusion rate was 0.
Wow.
Yeah.
Great.
So
So,
that's we select this valve for this particular patient.
So how about the situation in US? It has not been approved by the FDA yet,
It's not approved yet.
but there is a
Right,
large
Diogo?
study. 3
Okay.
years? Next year. So they have finished the enrollment. It's a randomized study against SAPIEN 3 or Evolute Pro.
Yeah.
I think both. The other
Both.
commercial available valves in
How
the
many
US.
patients? How many patients? 1,500. Okay, great. So we have 1,500 patients in this large randomized trial in the US testing Accurate New versus Evolute Pro and SAPIEN 3.
Yeah.
Great. So what are you going to
okay.
do now, Dimitri?
So-
Vanessa, have you measured?
Yes, it's still about 11
11?
millimeters of mercury.
So Dimitri, 11 millimeter is not enough to do a pulse dilation.
Sometimes there is this kind of discrepancy between the echo and the hemodynamics. We got 5 here.
So
The patient is 83.
85.
85.
83? No, 83. 85
so,
kilograms. I'm sorry.
I think that
It's
she,
okay.
she will get a good
Okay.
clinical course. And if you need it, Fausto, you can also pause dilate later if the
Okay.
patient has
Okay.
some
Okay.
issues with this gradient.
Okay, good. So what are you doing? Are going to do now?
So we're
Dimitri,
going to remove the Sentinel device.
I was just going to ask you, is this the right time to remove the Sentinel? Or
Uh,
should be the last thing you do?
the last thing you do.
Last thing, okay.
So the last thing you do is remove the Sentinel.
Yes, yes. So the valve has been removed, the angel controls have been removed.
Okay.
So now we're going to remove the Sentinel.
So great.
So can you
what
tell
do you?
how you're doing here, Dimitri?
Good,
So
Ricardo.
we are pulling the slider number 3
So
just to
you put in the filter and
resheath
you
the distal filter.
retrieve and resheathing.
Mm-hmm.
And then we're gonna rotate here just to try to make it straight.
Mm-hmm.
So Dimitri, besides the clinical outcome, is it common to find some material?
Yes.
Yes.
So
Almost 100% of cases.
it's very important to do that. But when we are doing like
Rotating.
in primary PCI, when we are pulling back the catheter with the thromboaspiration,
Yes.
sometimes you can get some embolization.
Yeah.
So that's very important what Dimitri is doing right now. Very carefully removing the Sentinel.
Okay. And then we're gonna
Good demonstration.
use the
Mm-hmm.
first slider.
And
Just
now
to
you're doing the same
capture-
thing with the second light. Okay.
Yeah.
Very
Okay.
nicely demonstrated. So now you can just pull with a wire together, right?
Yeah.
Everything together.
Okay, great. So now we have the Sentinel here with Ricardo. and Michele. And now you're gonna
We're gonna remove the eye sleeve, the sheet, and
so the
then
sheet, you are gonna use one ProGlide.
one ProGlide.
So what are you looking now?
So we're gonna use the dilator here, just because there was some tortuosity on the iliacs. Um pouquinho aqui.
Very carefully. So
Pode?
Só pra tirar aqui.
So
Let's see the
basically,
wire.
we bring in the
Let's see the wire.
system together again to prevent.
usually,
any-
okay.
So now
So-
the dedicated eye sleeve, we're going to remove it.
Leave the wire. We're gonna leave the wire. Just if we need another
Okay.
ProGlide, we're gonna. Pode tirar.
So Ricardo is just taken.
We always try to
introducer?
get hemostasis with one ProGlide, and if needed, we can place another one or on an angel seal.
Is exactly what you're doing now, and closing the femoral artery with only one
On
ProGlide.
one ProGlide. There's a study conducted in our institution comparing one versus two ProGlides. It was not randomized, but it was a register with a relatively good number of patients, and we didn't see any compromise of this technique.
What is the chance
Let's
to use only one ProGlide? I have asked this before, but can you mention again, Ricardo? Or maybe you can ask Dimitri.
Yeah, Dimitri,
Yeah.
what's the chance to you to get rid of with only one
In
ProGlide?
about 20 to 30% of cases, we need another hemostasis device, a closure
So
device.
70%, at least 70% of them, we use only one ProGlide.
So it's a safe approach. Yeah, you can use a second if you need it.
Okay,
It's
good.
a safe approach.
So in this case, you're going to use only one, it
Yeah.
seems to me.
Let's see, Michelle.
Now Michele is doing the compression. And how about the left? So you do an injection now just to...
Yeah, at the end, we always check if
check.
there
The
is.
contralateral and make sure
complications.
that everything's fine.
Let's see.
So you're...
Vamos tirar?
Sure that-
Vê que está sangrando. Vê se está sangrando.
See,
You see?
only one ProGlide is perfect. Just perfect.
Perfect. Yeah.
Congrats.
We're gonna
So-
give some protamine here.
Protamine.
Just half dose, and then we're gonna do another angel.
May you have
Just to check.
the camera for all the team here, please? Okay, great. Thank you. Dimitri, so we have finished this procedure. It was pretty safe. In 1 hour, we have been working with this, doing all the procedures that you saw here, implanted the accurate nail with pre-dilatation,
And Sentinel?
Sentinel. Exactly. Good, Ricardo. Thank you to remind me. Dimitri, you want to say some?
Only thanks, MedStream, for the opportunity to show how we work here.
Okay, great. Thank you for the ECHO team. It's a great demonstration, perfectly. Also the nurse, the anesthesiology. Caetano is the chief, is here. Oh, hi, Caetano. So the chief usually don't come to the cath lab, but now he's here. So thank you, Caetano, for being with us. So we have here Ricardo. Thank you, Ricardo, Dimitri, Michele, and also the Boston Scientific with the Brazilian valve, because it's made in Brazil. Now we are going to move to the next lab. Lab 1, you have a very nice case to demonstrate. I'll meet you there maybe in 5 or 10 minutes, Dimitri.
Okay.
Thank you.
Okay.
See you
Bye-bye.
there. Bye-bye.